Hello, and thank you for joining today's webinar. We are ready to begin. Today's webinar is eligible for 1 contact hour. Sigma Theta Tau International Honor Society of Nursing is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. The speakers and planning committee members have disclosed no conflict of interest and no relevant financial relationships. To receive contact hours for this NCPD session, participants are required to attend the webinar and complete the evaluation form, which will be emailed to all attendees approximately 1 week after the webinar. This webinar is being recorded and will be available via the Sigma repository within a few business days of recording. Following the presentations, we will have time for a question and answer session. You'll see on your GoToWebinar control panel that you can send a message through the questions feature. This is where you can type in any question you'd like to pose to the presenters. Be sure to hit send so the message makes it to us. We'd like to thank our speakers today for sharing their expertise with us. Our speakers today are Michelle Voss and Katie Christensen. Michelle is a BSN prepared RN who works as a school nurse at St. Louis Language Immersion School, SLLIS, through St. Louis Children's Hospital Healthy Kids, Healthy Minds program. St. Louis Language Immersion School is a K-8 charter school in the city of St. Louis. They teach Chinese, Spanish, and French. Michelle is a member of Sigma, ASHA, American School Health Association, and Missouri Association of School Nurses. In July, ASHA awarded Michelle the School Health Professional of the Year Award in 2021. She was also nominated for the Life Changer of the Year Award in 2022. Katie Christensen is a registered nurse from Utah, United States. She works for the Utah County Health Department. This fall, she is beginning her 4th year as a school nurse at a special education school in a large school district. She earned her BSN from Brigham Young University, where she participated in research on public health and school nursing. She presented the findings of one of her studies titled Barriers to School Nurses' Role During a Disease Outbreak at multiple conferences, including a Sigma conference in 2018. Welcome and take it away, ladies.
Next slide. These are the learning outcomes for our presentation today. Next slide, please. I wanted to thank Sigma Theta Tau International for the opportunity to be able to share our experiences as school nurses with everyone. And we wanted to recognize a few of the countries that participate in STTI webinars. Please excuse the lack of accent marks. I used Google Translate. And I would also like to acknowledge and validate all the dedication and unseen work that nurses do and have done throughout the pandemic. Next slide, please. I'm Michelle, and I work as a school nurse in a public charter school in St. Louis, Missouri, in the States. It's an individual school. It is not part of a school district. We have approximately 520 students enrolled. About 40 of them are virtual students that are virtual throughout the whole year. We have a pre-kindergarten that is housed on site but is not part of our school. They just rent space from us. And as was said previously, it's our school, our charter school is a language school, which is Chinese, Spanish, and French, and they're all taught by native speakers. Our school opened last year, the 10th of August, full days, 5 days a week, while most other schools in our area remained virtual. We have trimesters at our school, and we slowly increased enrollment by each trimester. When school opened in August, we started with approximately 150 students. Then we went up to about 225 students second trimester, third trimester, about 325 students, and that was a total enrollment of 450 altogether. We started with strict school mitigation policies, and as success grew, the school mitigation policies relaxed. We always maintained our Department of Health and CDC policies. Next slide, please.
I am Katie Christensen, and originally I was asked to participate in this presentation because in the past I have participated in research in school nursing. However, currently I'm not doing any research. I am working as a school nurse. So I am just at one school like Michelle, but my perspective is a little bit unique because the school that I work at is a special education school for children with severe disabilities. The school is part of a very large school district. So while the school that I work at has about 120 students, our district has over 80,000 students. In my area, school nurses are employed by the county health department. So I work really closely with other school nurses in my district, but I also work with nurses who do epidemiology and other public health functions. A little bit more about the school that I work at. So our school is ages 3 to 22. In the US, children with severe disabilities can stay in public school until they're 22. And we also opened our school on time last year and had a small portion of our students chose to be in virtual learning, but many of them came in person. At our school, we have a wide variety of health concerns. Since it's a school for severely disabled children, we faced a lot of unique challenges in stopping the spread of COVID at our school, including students not being able to wear masks or social distance, which I'll talk about a little bit more later in the presentation. Overall, our presentation is going to focus on comparing our two schools and how we responded to COVID-19, since Michelle is at an urban charter school and I am working at a suburban school in a very large school district.
A few housekeeping things. These are some of the acronyms that you'll be seeing and we'll be referring to throughout the presentation. There is also a handout that's in the sidebar. You can download it and print it, and that's some of the things that we thought that would be helpful, some of the tools that we thought that would be helpful, and we'll be referring to those tools throughout the presentation. Next slide, please.
Okay, so clear communication. If you get one thing out of this presentation, we really hope that this is it. We need clear communication with all parties when we're dealing with COVID-19. We're working with a lot of different groups, including students, parents, teachers, administrators, the community, the health department, doctors. We are trying to navigate all of the regulations and guidelines that are changing so frequently with all these different groups. And it can be very difficult, but if we can communicate clearly with these different groups, we can hopefully minimize confusion and angry feelings that may come up.
Whole school, whole community, whole child is the WISC model. And we looked at our material for our presentation and realized that it lined up with the WISC model. Putting the student first, bringing the child, the school, the community together to benefit the student. Katie and I are not professionals at using the WISC model. We are beginners. But we thought it was important to incorporate our experiences with COVID-19 and school nursing this way. Next slide, please. We will begin by discussing the way each of our schools responded to the pandemic last school year. When the pandemic began, treatment was divided into pharmacological treatment and non-pharmacological treatment. Non-pharmacological treatment then became mitigation strategies. Next slide. School-wide strategies, standard CDC practices. We all look to the CDC and our Department of Health to guide us with mitigation strategies. As a charter school, SLIS was able to make its own guidelines in addition to those that we had to follow with CDC and Department of Health. Standard was shields on student and teachers' desks, shields on cafeteria tables, in addition to spacing, not mixing classes. Teachers went to classrooms to teach different subjects instead of the students moving to different classrooms. The students stayed in the same room. We didn't have library, art, music until the third trimester. At my school, SLIS, if a student or staff member went outside the St. Louis area, say Labor Day weekend, somebody went to Chicago, that person had to quarantine for 14 days before they could return on site. And that was a school policy that we made. That policy ended second trimester around Christmas time. And in addition, the nurse gained responsibility of calling for contact tracing and quarantining in most schools. Katie?
So at our special education school, things looked a little bit different. The things that you see listed on the slide, like Michelle was saying, are just the standard practices that were recommended for schools in the US. But at our school, we had to make a few changes. First was related to mask wearing. We probably have fewer than 5 students who are capable of wearing masks. And so our students didn't wear masks, but it was required for staff or anyone else entering the school building to be wearing a mask. We also were able to physically distance students who are wheelchair bound or students who are capable of remaining in their desk during the school day, but most of the students are not able to follow instructions well enough to maintain any sort of physical distancing. So that wasn't really something that we could do. But despite these limitations, we really had very little COVID spread among the students, and the majority of the cases that we had at our school were from staff members who got COVID from outside the school. We did have a few cases where staff members got COVID-19 from each other, but overall, while the students weren't able to engage in a lot of these typical mitigating strategies, having the staff participate in the mitigating strategies proved to be very effective when the staff were following them properly. So in addition to this, both Michelle and I had to do daily screenings at our school. These were recommended at the time in both of our areas. So in Utah, we did daily staff and student temperature checks when people arrived at school. We also, of course, would send students home immediately for any COVID-like symptoms. So if you can see this graphic that's at the bottom of the slide was given to us by the state of Utah, and it shows all the symptoms that we sent students home for. So if we had a student who came to our office and was coughing frequently or definitely had one of these listed symptoms, we would send them home. They would be sent home until their symptoms resolved, or if they had a fever, until the fever had been resolved for 24 hours. At this time, we would also encourage them to go get a COVID test because that was really helpful for us and for them in determining when it would be best for them to return to school. Michelle?
At the start of the school year at SLIS, all staff had to test negative for COVID before they could enter the building. We couldn't do a screening, a digital screening for students like we did for staff members because not all students in the school had access to computers or internet. Because remember, the students that had computers and internet were the ones that were doing virtual learning, not the ones that were coming on campus to do in-person learning. So it was decided that the nurse would go to student classrooms to ask health questions, and we'll talk about that more in student-specific mitigation strategies. Next slide.
Okay. So, in both of our areas, the school nurses were responsible to take on the role of doing contact tracing, which is not something that most school nurses are used to doing on a regular basis. So for both of us, this was new. In Utah, all the schools were required to follow the COVID-19 school manual, which is this image that's on the slide. That's like the front cover of our manual. This manual was very detailed in giving recommendations for isolation and quarantine in different scenarios. So this really helped us manage our contact tracing and know what we could and couldn't do in different scenarios. In addition to manage our contact tracing, one of the nurses in our district created a Google Sheet that we used to track positive cases in each school and the individuals that they had close contact with, which I'll discuss more on the next slide. But Michelle had to handle contact tracing a little bit different, so she'll describe that.
There was no manual because my school is an individual school. And so anything that we needed to do, I had to develop forms for. And so everything was paperwork, and I'm not tech savvy, so I didn't have a fancy data sheet. And I had to develop my own form for everything. And it was just manual calling in everybody, manual keeping track of everybody, and doing it all by myself. Next slide, please.
So this is the image. This is an image of the tracking sheet that we used. This document ended up being shared with the school nurse, our principal, and our head secretary. So it was very helpful for keeping everyone on the same page and informed about what was going on in the school. This spreadsheet was a smart spreadsheet, so it would make automatic changes, like when students finish with quarantine, or you can see here where it says value, those are dates that would automatically populate for us. So this was so helpful. It helped us keep track of who was supposed to be out of school and for how long. We even used on the right-hand side, you can see there's an email portion. We would use that to record when we had contacted parents to let them know that their student needed to isolate or quarantine. On the bottom, you can see there are tabs for previous cases. So once a student was finished with their isolation or quarantine, we would move them to previous, and that would help us in the future if we needed to know if someone had had COVID-19 in the past or had been on quarantine in the past. Utah also had threshold numbers for classrooms and whole schools when they would need to be closed due to COVID-19, and so this spreadsheet would also auto-populate those numbers and keep count for the nurse. This was especially helpful for nurses who cover multiple schools so that they wouldn't miss it if a school or a classroom was getting close to those threshold numbers. A link to a blank version of this spreadsheet is included in our handout. So if anyone is interested in using something like this, you could use that link and kind of create your own for whatever area you are in.
For school-wide strategies, changes in the nurse's office, our school had numbers on each door for the maximum occupancy. And of course, the nurse's office didn't have that. My office, what I decided to do was divide it into a mask on, mask off area. So the nosebleeds, facial wounds, oral medications, inhaler use would be on one side. And on the other side would be the mask on treatments, bloody knees, swollen ankles, things like that. I used different color chairs so that students would remember where they were sitting. And also I had a one-touch rule. You touch the chair, that's where you ended up sitting. And once they left, the chair got cleaned. The nurse's office was on the second floor, and students were sent to the first floor if they had COVID-like symptoms. And there was a room off on the first floor so that the receptionist watched the student and they were picked up by their parent when they were sent home. If the student was medically unstable for any reason, whether it was COVID-like or something else, what I would do, especially if it was COVID-like, I would keep them in the office, email everybody, and just say, no more students to the nurse's office, and keep the student in my office until the parent came to pick them up. And if somebody had to be seen, I would just see them in the hallway outside the door of the nurse's office. And then when the parent came and I was called, I would take the student down to the parent because parents weren't allowed in the building. And for contact tracing for the nurse's office, since everybody that comes in the nurse's office is sick, I just kept a log of everyone that entered the nurse's office, and it was date, name, time, and whether they were wearing their mask or not wearing their mask when they entered the office. Next slide, please. Community-linked mitigation strategies. Each school nurse in St. Louis, actually, I think it was a state thing in Missouri. We were assigned a specific contact at the Department of Health for COVID-19 related issues. I had a wonderful contact. She was knowledgeable, got back to me within hours versus days. Whenever I had requested a release date, informed me about updates for guidelines. Whenever the Department of Health changed guidelines, she provided me with reference links. Communication was ideal with my liaison person. The Department of Health also administered single-dose Johnson & Johnson vaccine for all the staff members at our school. And what we did was the next day, we called it a snow day, and that way everybody could handle their vaccine side effects. Katie had a different relationship with Department of Health at her school.
Yeah, it was quite different from Michelle because I am an employee of the health department. So that gave me some benefits that other school nurses probably wouldn't have. It also made a few more requirements that other school nurses maybe didn't have as well. The school nurses in our area were required to do community contact tracing for part of our hours throughout the school year. And we also were required to help administer vaccines when that became available. But we had a lot of benefits as well. So I was given direct access to the epidemiology records for our state, as well as direct access to epidemiologists at the county level. So when I had questions about cases, often I could find the answers myself because I had access to our COVID-19 test results in the state. I didn't have to wait for someone else to do it for me. I could just do it myself, which was great. I also attended the meetings for the county contact tracers, and I worked very closely with the epidemiology nurses, which helped me stay up to date when guidelines were changing or when there were issues in the news that we would anticipate parents were going to have questions about. So those were some great benefits, but were really unique to me being an employee of the health department.
Our local physicians as part of the community. I worked with student physicians, of course, and SLIS developed a relationship with a local pediatric infectious disease physician. He worked with the CDC doing research and published a triage algorithm that we used and Department of Health adopted. He was available for any COVID-19 related questions. He and a partner did a virtual meeting educational presentation for all the staff at our school before school started so that they could have their questions answered about COVID and how it related to how they would relate to students. And then before the vaccine was administered, they did another educational presentation, virtual of course, for all the staff, and answered all their questions about it again. And so that was a wonderful liaison that we had. We met with him once a week, we meaning the superintendent and I and the physician met once a week, and we would just talk about COVID cases and any questions that we had, how it would impact school, the community, etc. Next slide. All of our school policies were based on CDC, Department of Health, Department of Education. We also had unique school policies, and things like no parents in the building, no interns, no outside vendors. So there were no student health screening, no vision, no hearing, no glasses, no dental, but we did allow flu vaccinations that year because we thought that that was very important. Katie?
So, like Michelle, we had a few school-based policies, but not too many. We did have no volunteers, but we did allow limited access for interns and parents at our school. In general, the governing body for us was the state of Utah, and the state really made 95% of our school policies because we had to follow their guidelines. Occasionally, we did have questions or problems with the guidelines, but even then, we were able to escalate our concerns to the county level or even the state level if that was needed. For example, we had a problem with, we have several students at our school who have trachs, and there weren't very good guidelines, or there weren't any guidelines for how to help those students be safe at school. So we worked with the county to create some guidelines so that those students could be safe at school and keep other students safe as well. Okay.
We had a unique communication system at SLIS with parents. The teachers and the parents always texted each other back and forth. And that became a wonderful help when it came to COVID. Before school started, about a month before school started, we sent out our infection control policy to all the parents so that they would know exactly what was expected of them. And so parents would text teachers and say, hey, Johnny has a runny nose and a fever. Can you come to school tomorrow? And the teacher would forward that to me, and I would get in touch with the parent, and I would say, you know, just do an assessment, what's going on, and recommend, need an evaluation by a physician, need to go to urgent care, need a COVID test, need to stay out for 24 hours after symptoms have resolved, or whatever the situation required. But what that did was it prevented a sick student from coming to school. And the same thing happened with staff members. Staff members would contact me and say, I'm experiencing this and this. Can I come to school tomorrow? And I would say, no, you need to do this, this, and this. I would contact the principal. I would contact HR and say, I recommended this staff member not come to school for this reason. And we just had this wonderful communication system, and it worked really well. And the goal was to prevent a sick person from coming into the school building. And it meant that I was working at night, it meant I was working on the weekends. But when you're preventing a sick person from coming into the school building during the times of COVID, it worked really well. Next slide, please. So, as I previously mentioned, in St. Louis, the Department of Health requires students to have health screening. and SLIS decided to have the nurse screen students in classrooms. Students caught on pretty quickly that if they answer questions a certain way, they would get to go home or they get to spend time in the nursing office. So I had to become a detective. I had to learn to change my questions if I wanted different answers. I had to learn to depend on my nursing assessment skills and not rely only on what the students said they had, that they might have a sore throat, but is it red? Is it swollen? Do they have white spots? Do they have a fever? And were they eating crunchy bagels and drinking orange juice without it bothering them for breakfast in the morning? Um, so I really had to rely on my assessment skills and communicating with the parents. I learned that if I don't like the answers that I'm getting, I need to change a question. I learned to look for nasal mucus, pull down that mask, look in that nose, and see, is there anything there? Just because they say they have a runny nose doesn't mean they actually have a runny nose. Also listening, are they sniffling? Are they swallowing all the time from postnasal drainage? Um, by the end of the school year, I was only sending students home that had positive assessments, regardless of their verbal complaints, unless when I called a parent, they decided that they wanted to pick them up anyway. And I realized that parents have limited resources, financial or transportation, and I refused to send a student home unless they had authentic symptoms and they had a positive assessment. Next slide. And this is the algorithm that was created with some of the physicians in the St. Louis area, the one that we worked with being one of them. And there's a link in the handout that we have in the sidebar. And I worked with this religiously and still am this year. And so I developed a form to go with this algorithm, and it has the symptoms, and I wrote out the symptoms. It has what to do, and I wrote out what to do. And so a person came in, they had a symptom, I highlighted the symptoms that they had, I wrote out I highlighted what they had to do in response to the symptoms, called the parent and sent that page home and said, this is the symptom they had, this is what they need to do before they can come back, and sent them home with that page that I made up in response to this. Next slide. Now we're going to specifically address communication strategies we used to respond to COVID-19 at school last year. It's all about keeping lines of communication open, making sure that the designated people have the information that they need to do their job, letting a teacher know when a student is going home and will not return tomorrow or until symptoms have resolved, informing staff of updates to guidelines, letting administration know that a student needs to switch from in-person to virtual learning, letting staff know when a student is returning from quarantine or isolation, having scheduled meetings with administration so that you're both on the same page and updated of changes and expectations. I had weekly principal meetings. I had superintendent meetings weekly with the infectious disease physician. I had biweekly nurse manager meetings, and just keeping everybody on the same page, emailing people, texting people. Communication is really, really the key, especially with this pandemic. Next slide. So if staff have to isolate, quarantine, have to have a COVID test, they have side effects from the vaccine, I contact HR, I contact the people in administration that need to know, so that the staff member doesn't have to take care of everything. They just know that they contacted me and I've taken care of everything else. Whenever a student was being sent home, there is a group that the principal decided that this is the need to know group, and I would text all those people as it occurs. The person is in the nursing office. I decide to send them home. I text that group of people. This person is going home now and their mother's been notified and the mother is coming to pick them up. At the end of the day, I email the teacher and I say, this person was sent home and they're not coming back tomorrow, or they're not coming back until symptoms have resolved, or they should not come back until I have medically cleared them, or they need to switch to virtual and it's CC'd with the principal and the principal will take care of switching them to virtual. So there's many, many layers of sending somebody home and the layers of communication that it needs to go through. Katie?
Yes, definitely. So many layers, but really the nurse can be that point of contact for everyone to connect people with resources or things that they need when they are being sent home or need to stay home to isolate or quarantine. That was something that ended up being very important, was for the nurse to be the one who was knowledgeable and able to connect everyone with the resources that they needed or wanted when that situation came up. So being at a school, most of the school staff are not used to dealing with protected health information. Obviously, nurses are used to dealing with that, but school staff, this was new for them last year. So at the start of the school year, we did decide who got to know the names of all the positive COVID individuals. So we shared, for example, at my school, it was the principal, the head secretary, and the nurses. But whenever a situation came up, there were other people that would need to know as well, like Michelle was mentioning, the teacher or other staff. Usually when we were contacting staff, wherever possible, we would try to use non-identifiable information or just give whatever detail was needed. So for example, we have a lot of students who work with speech therapists at our school. If I needed to talk with or notify the speech therapist that one of their students was going to be on isolation or quarantine, really I would just give the name of the student and the date that they were coming back, and not really give a specific reason why, unless it was needed for that speech therapist to know. Schools, especially smaller schools, have a lot of gossip about what's going on. People just want to know what's going on. So we had to specifically teach the staff that they can't be gossiping about people's protected health information. When staff ask questions, or when parents would call and ask questions about who was the positive case and should they be worried, we would just remind them that if they were not contacted, then they or their student was not a close contact and they don't need to worry about it.
I would always have a parent that would say, my child is a close contact and they tested negative and they'll be back at school tomorrow. And I'd have to explain, I need to check with Department of Health. Those are the guidelines we must use. And I'll get back to that parent. And I get back to the parent, do education, and use the authority of the Department of Health said, this is the date that we're going to use. This is what is recommended. And the same thing with working with students' physicians. When I say we're working with a specialist and this is what is recommended, or this is what the Department of Health says, or this is what our specific school policy says regarding this, they are usually respectful of that and just say, you know, that's okay, you do what you need to do for keeping your school safe, just keeping those lines of communication open. But it usually helps when I would say, Department of Health said this, the other physician said this. This is a school policy, as opposed to, well, that's just the way it is. Child-parent communication. Parents have insight as to why students want to go home when the report of the symptom doesn't match the assessment of the symptom. A call to the parent of a student that usually doesn't complain, yet the assessment is negative, parents usually have the missing puzzle piece. And using language when you're talking to the parent that is non-blaming, instead of your child is lying about or your child is faking, saying the assessment does not match the complaint, or it's a seemingly not authentic with complaint, when speaking with parents. And parents figure out what you're talking about. And they'll say, oh, grandparents are visiting now. They just want to come home and be with grandma and grandpa. That's okay, just send him back to class. And they just give you that puzzle piece when you have that student that never ever complains, and they're complaining about a sore throat all of a sudden, and you can't find any assessment as to why. So cluing in the parent as to what's going on always or usually helps with figuring out what the puzzle piece is. And I found that students feel safe in the classroom. And when I would go from classroom to classroom doing the health assessments, the students opened up and asked questions and felt free. And I would go to a classroom and I would say, is anyone coughing today? And all the students would point to the one person that's coughing, because they all knew you're not supposed to cough, and they would point to the one person that's coughing. And I just thought that was absolutely hilarious. But they were comfortable in their homeroom, and they were free to tell on their classmate. Katie?
So at our school, we had a few different challenges. We don't have very many students who are verbal, so we didn't have a lot of students who were making inauthentic complaints. But we do rely on staff to report a lot of symptoms to us. And we sometimes have some staff who are maybe a little bit overzealous in their reporting of symptoms. So a lot of the time what was helpful for us was to assess the student, wait 15 minutes, and then assess again, or watch them for 15 minutes if the complaint was something like coughing. But for something like a fever, often if we wait that 15 minutes, the temperature would return to normal. Many of our fevers ended up being, the student was wearing a jacket, or they had just been sitting on the bus in the sun. And then that 15 minutes was enough for them to cool off, and their temperature would return to normal. When we did have to call parents about their student having symptoms, I really tried to keep in mind that all of us have had added stressors in our lives related to COVID-19, but parents of school-aged children have had especially a lot of changes to deal with. Sometimes parents are angry or upset when their students were being sent home or quarantined for an exposure, which is understandable, but communicating clearly and directly really helped with this. Just trying to be kind but direct and reference the school policies, which the parents already knew about, like Michelle talked about. This really helped the parents feel like, number one, like the school nurse knows what they're doing, and also that their child was being treated fairly and wasn't being picked on or sent home for no reason. So our 2021-22 school year, this is the school year that is, things are the same but not the same. So first, In approaching this school year, it's important to attempt to find unity between nursing and administration at the school. Depending on the attitudes and the COVID-19 spread in your area, it might be difficult to find a unified approach to this coming school year. Some administrators or principals or district leaders may not agree with your desired approach. This is where we do what we can, but we just have to remember that we can't control everything when it comes to dealing with COVID at our schools. Another thing that is helpful for this coming school year is networking. So it's very helpful to network with other knowledgeable sources of support as you face COVID-19 at school. I had other school nurses and epidemiologists to help me. Michelle had the physician that she told us about to help her. And this can really make you feel like you're not having to do everything alone. Michelle, do you want to briefly describe how you formed that relationship with the physician?
The superintendent, who in a charter school is higher than the principal, was telling me she had to stop what we were doing because she was going to go and meet with an infectious disease physician. And I thought, oh, why are you meeting with a medical person? I said, oh, what's that about? And she said, oh, I have a stand-in meeting with this physician to talk about COVID-related issues once a week. And so I said, well, can I come to that? I said, because I'm the school nurse and I'm really interested in that and I would love to learn about those things. I'd like, can I come to that? And she said, oh, you'd like to do that? And I said, yes. And so she invited me to the meeting, and ever since then, I've been going to the meeting. But I had to speak up and invite myself to the meeting in order to form this relationship. And I talk to him all the time now. I text him on the weekend and get advice from him, and he emails me and gets on video chat with me when he's out of town doing research. And it's incredible. We have a nice relationship, but I had to put my head out there and say, why is an educator meeting with a physician when there's another medical person here that could do it? So sometimes you just have to kind of step outside your comfort zone and do that, because I'm not that kind of person usually.
Okay, next, protective measures. So this is where things may be the same as last year, or it may be very different depending on the attitudes in your area. So some schools might be proceeding largely in the same course as last year, but others are facing a different situation. So whatever the situation you're in, wherever possible, there are a few things that you might be able to do to, as far as protective measures at your school. PPE and cleaning supplies could be limited by budget, but you can advocate for yourself wherever possible to try to get supplies that you need. We can also encourage mask wearing, frequent hand hygiene, and staying home when you're feeling sick. A good way to do this is leading by example, wearing a mask yourself, or putting hand sanitizer where it's visible for people. Signage can also help encourage staff and students to engage in these measures as well. But if you live in an area where mask wearing is not required, it's important to be aware that there may be some bullying associated with mask wearing in these areas. So this isn't something that a nurse could really stop alone, but it's something for nurses and teachers to be aware of so that they can try to discourage it whenever it is happening. We can also, of course, encourage vaccination wherever it's possible, but this might be limited by vaccine availability or the age of your student if they are too young to get the vaccine.
I would suggest learning about where you can get the vaccine. CDC has a site that you can put in your zip code and it will tell you where vaccine is available. in your neighborhood. It also has a site that I put on the handout, that it has COVID information in different languages, so that, and mitigation strategies for different countries to use. And so that's the link that's there, but it's also on the handout. And to just educate yourself, benefits and risks on not being vaccinated, being a resource to staff, parents, students, so that when they have questions, you can know where to find the answers, or you can have the answers for them. Because we're living in a time where people don't want to hear you pushing information on them right now. So being ready for when they ask questions. Next slide. And the administrative team members who you need to communicate with. Does HR need to know when staff is out with COVID-related issues? What do they consider COVID-related issues? Testing, symptoms, quarantine, isolation, waiting for test results. Who are the key staff members that need to know when a student is out for days related to COVID? Switching from in-person to virtual, who do you need to talk to about that, or let know that that needs to be done? A lot of times school funding is tied up in some of this, and sometimes it's the difference between a student being labeled truant versus COVID-related absence, because they're absent because they're responsible and staying home because they're waiting for a test result, not because they are truant and they're absent for 4 days in a row. They just went somewhere where it takes 4 days to get a result of a COVID test. And share, merci, gracias. Thank you very much for your time. We really appreciate it.
Thank you for sharing all of this great information. We do have a couple questions that I would like to pose to you from our participants. One question is in regards to the safety and environment of the school. So did you work with school safety, environmental health experts regarding air filtering and fresh air supply through building ventilation systems? Wow, that's a great question.
For us, we did not, because we decided that all our different layers of mitigation standards that we did, that we didn't need to upgrade our air filtering, and students went outside for recess, but we didn't have classes outside. Like sometimes people talk about having classes outside. We just had individual classes in separate parts of the playground doing distanced play outside, and we had more adult monitors making sure that they were having distanced play outside, and they were able to take their masks off outside. And so inside, we only had one class at a time in the hall. We only had one class at a time on the stairwell. We only had one class at a time in the cafeteria. We opened up the gymnasium and changed it into a cafeteria, and a different class ate there. The seating was further apart, and they had shields. And so with all these things, and we have really large classrooms, so we were able to do the 6 feet last year when we had a smaller amount of students. This year we're doing the 3 feet. But we had the 6 feet, we had the shields, we had the masks. Everybody wore masks. And so with all the different mitigating standards that we used, it was decided that the air filtering was not needed.
That's pretty similar to what ended up happening for us as well. But I think air filtering was a really big topic at the beginning of last school year, something that people had a lot of questions about, concerns about. And what ended up happening for us was that was something that was covered. Since I work at a school district, that was something that was covered at the district level. And the experts there ended up deciding that whatever air filtration system we already had was adequate. And we, again, like Michelle was saying, just attempted to keep students with each other. They stayed in their same groups. So we didn't, like I said in the presentation, we weren't able to do the distancing or masking the same as other schools, but we definitely were able to keep students in their same groups, keep them mostly in their classrooms. Some of them even ate lunch in their classrooms. And so mostly they were just in class or in or at recess. Sometimes they did go to the gym, but if we did have a student go to like a confined space, like we had our sick room for kids who had symptoms, once that room was used, there was, I can't remember how long it was, but a specific amount of time that was determined by the environmental health that we had to leave that room empty. And then it would go, then our custodian would go and clean it based on guidelines that she was given from her leaders at the district. So that's how that worked for us.
Great, thank you for answering that. This question, might be more targeted to Michelle. Do you see in the future school nurses will have direct contact with health departments as the pandemic criteria begin updates? I think this kind of goes hand in hand with you being an advocate to have conversations with the physician in your area, but what do you think about working with the health department in the future, Michelle?
I still have a contact with the health department. So I have an assigned contact with the health department that I work with. And I have them to ask questions of for updates, for guidelines. So I work with the health department also.
And I'll add, even though this question doesn't apply to me as much, most school nurses should have some contact with their health department because there are other illnesses that would require like quarantining in the school, like measles or something like that. And so in a scenario like that, you would also be working with the health department. So it's good if you have a contact, if you already know who that contact is. So that when scenarios like that come up, you can work with them.
Great. Thank you for sharing both of your insights. One more question I think we can squeak in. This might be a short one. Who did the COVID testing at your sites, and what type of test did you use?
So at
COVID tested at our sites.
Yeah, at our school specifically, we did not test on site. But in our area, there was, like in our district, there was some on-site testing, and that was done by the school nurses. They did the rapid antigen, or I don't know what the type is called. Now I'm like blanking because I've got people watching me, but they did do some rapid testing at some of the schools, and the school nurses did that. But for my school, and I think this is the same for Michelle, if people needed testing, we just had a list of places we would refer them to, or we could help them set up an appointment if they needed it at a local hospital or doctor's office, or state-run clinic or something like that.
Yes, we applied for and got the rapid antigen test in the Bionex now, but we made a conscious decision to not use it because the the way it worked was if you had symptoms, you had to go home. If you were negative, if you were positive, you had to go home. So either way, the student had to go home. And last year, I was doing screenings in the classrooms and sending students home with symptoms, or they were being sent to me if they had symptoms. So we were sending them home anyway. And we just decided to just not test them and just keep sending them home when they had symptoms.
Great. Yeah, that makes sense, to send them to their primary care or to a clinic,
Mhm.
etc. Um, great. Thank you for answering those questions. We do have a few more questions that we won't have time to get to today, unfortunately. I want to thank both of you for presenting today and for sharing all of this great information. Sigma is grateful that you took the time to share with our audience, and we look forward to hearing more from you in the future. We hope that you have enjoyed this webinar. As a reminder, 1 week from today, we will email you the link to the evaluation so you can obtain your Nursing Continuing Professional Development Certificate. Be sure to check out Sigma's upcoming webinars, podcasts, and resources to support you and your colleagues at sigmanursing.org. Also, previously recorded webinars and podcasts are freely available on the Sigma repository. Thank you for joining us today and have a wonderful day.